The mission at Hope Cancer Care Nevada is to provide world-class care closer to home. I'm Dr. Mehdi. I'm a medical oncologist and founder of Hope Cancer Care Nevada.
This is Eye on Cancer with Dr. Mehdi and Linda Cass.
Good evening and welcome. I'm Linda Cass and you're tuned in to Eye on Cancer. This is not a live broadcast. You do have an opportunity to call in or email your questions. And speaking of questions, we have the answer man. We're here with Dr. Raja Mehdi, who is our Pahrump medical oncologist. Good evening, Dr. Mehdi. How are you this evening?
Good. Thank you.
All right. And speaking of those questions, we have several that came in during the week, and we'll start right away. Our first one comes from Linda D., and she'd like to know at what age women are more vulnerable to breast cancer.
Thank you for having the question call in. The incidence of breast cancer increases with age. So women in their 60s and 70s, there's a higher incidence. But increasingly, there are women in their 30s and 40s been diagnosed with relatively aggressive type of breast cancer. So there is some controversy regarding what age to start the mammograms, but generally it's acceptable to start at age 40 and do a yearly mammogram. If you do have a family history which is relatively strong, you could opt to start it earlier. But it spans pretty much, I've seen patients in their 30s right up to in their late 70s.
And, that brings up a question. You mentioned the mammogram. And now I know that there are different ways to check physically for the presence of cancer. One is the mammogram, and another is a sonogram. In your experience, is one better than the other?
A sonogram is not a screening test.
Okay.
So how most cancers start, or we like to catch them earlier, is at a stage where they're generally not formed a mass or a nodule that you can feel. We like to catch them earlier with the mammograms where they're starting out as calcifications.
Okay.
And so the sonogram complements the mammogram, but it does not replace it.
And that brings up another question. Calcification, could you kind of define that for the audience?
Well, it's seen as a cluster, white clusters on the mammogram or the scan, and it's supposed to indicate early or cancer which is starting out.
Okay.
So the radiologists look at the mammograms and have preset criteria. Radiologists are the doctors who specialize in reading the X-rays.
Okay.
So mammogram is a kind of an X-ray.
Got it.
That they take, and then they can specify that which kind of calcifications or shadow on that X-ray denotes a higher likelihood of cancer. And then they would recommend either a sonogram to supplement it or a biopsy.
Okay. Well, in your descriptions and things, because I've had the breast cancer, I automatically compare it to my experiences, and the early onset of periods. Mine started at 9, which was, that's extremely early. I also smoked, which is a no-no. Don't do it. It's not cool, but it does make you think about the things that we do every day that that can bring on cancer. And now the family history. I've heard a lot of talk about family history, but that's not necessarily like a guarantee that you're going to be diagnosed with cancer, right?
Yes, and the other way to look at it is that many patients feel that if I do not have a family history, then I don't need the cancer screening. 90+% of cancers are diagnosed without a documented family history. So when you do have one, it's good to know and find out the genes and if you're going to pass it on, but that's a very, very small minority of cancer patients. We may find out more about it in the future, but at this time, the vast majority of patients who are diagnosed do not have a family history. So you do not need a family history to go get your screenings done. That's the big, I would say, the message.
And the age is getting younger and younger. I know that I was 46. Mm-hmm. And at that time, in 1994, I thought, but I'm only 46 years old. And it usually, at that time, it wasn't...
It's kind of unreal.
Yeah, really. And but I've noticed more and more lately that it seems that women are becoming younger. And, it's kind of a scary thing, the aggressive, mm-hmm. the part of it. But I would like for people to have an opportunity to get the number. It's 775-727-9400, and the email address is eoc.kpvm, eoc@kpvm.tv, and later in the week, or even right now, you could call in, but this is not a live broadcast, folks, so we'll be right back with more. Welcome back. You're watching Eye on Cancer. I'm Linda Cass, and we're here with our medical oncologist right here in Pahrump, Dr. Raja Mehdi. And we had a lot of questions this week, so we're going to just move right along. This one is interesting. Why must teeth be removed in the case of tongue cancer? That's all you, Doc.
That's generally done before the radiation. And when you are treating radiation, which is given to the head and neck area, it can cause the blood supply to go away. So it's essentially it can cause necrosis, which is like decaying of the whole jawbone if you do not remove the teeth in advance. So it's a very specific, I should say, adverse effect or side effect of radiation therapy to the head and neck region. And before we start, generally we'll have the patients get their teeth removed.
Wow. So if they don't have their teeth removed, what would be the outcome?
Generally they'll get infection, and then it won't heal because the radiation knocks out the blood supply. And then the whole jawbone can actually get affected.
Wow.
And it's very hard to then treat that.
My goodness. I had no idea. I had never ever heard that before. So, my. And then Shannon M. asks, why does hair loss occur with chemotherapy?
Chemotherapy, the traditional chemotherapy, targets rapidly dividing cells, and that's how it's able to attack the cancer cells. So the cells in our body that are rapidly dividing or growing, like the hair, the lining inside the mouth, the nails, skin, all of those organs or areas are affected. More and more we have now targeted therapies that are not traditional chemotherapies, and they have different mechanisms of action. So I would say a good 30% or so of patients these days are able to avoid hair loss. That's generally not the primary determinant of what we choose for a patient. Obviously, we choose the best drug.
Right.
But there are now treatments that patients sometimes don't.
I know in my mom's case, there were times when she did take chemotherapy, and that's what they called it, but it was like in pill form, and she did not lose her hair. And then there were other times that she did. And I know with me, with the diagnosis, when I heard the words, "you have cancer," that is the very first thing that my surgeon told me, is that it's really too bad, because my hair actually was a lot longer at that point. She said, "Linda, you're going to lose your beautiful hair, and I'm so very sorry, but that's going to be the case." And, that bothered me more than anything else. Is
Age
that
46?
Yeah, in addition to everything else, the stigma with cancer at that time, and the fact that it is so out there and in your face that you're it's like you're branded.
Absolutely. And it's a very, very natural feeling. And it's important to mention that since some patients lose hair and some don't, first of all, it's not a function of the intensity of the treatment. That if you're not losing hair, you are watering down the drugs or not using the higher dose. That's one common feeling which is incorrect. And the other is to cross comparison between patients. So and so I know had pills or something and they didn't lose hair. How come I can't have it? That's most likely because that medicine is not the most effective for your particular type or stage of the cancer. Even within the same cancer, say 2 different breast cancers, you could have totally different types of breast cancer, and for one, the treatment or the drug could be totally different. But it does make us look good if we can tell the patient that
we're not going to lose our hair.
Yes.
It is interesting, though, that there are the different types. People do compare notes, and in my experience now, going through it with my mom, seeing all the different therapies that they use. She had cancer several times, and it was scary for me because I saw some of the side effects. But we're talking now, 40 years later, her therapies were in the 70s and the 80s, and hers went from 70, 80, 90, and in the 2000s.
Yeah.
And so things changed.
It's the old paradigm of treating cancer was you throw something that works on all dividing cells, and kind of, it'll kill the good and the bad, and then you'll recover. Now we treat cancers based on their genetic makeup. So we have the capability of actually testing the DNA makeup of the cell and then matching the drugs to it. So it's a lot more sophisticated than wanting to use what somebody else had for their type of cancer.
Boy, am I glad to hear that. That's a lot better. In '94, I was still in the to kill it all, and it does make you extremely uncomfortable. Because your hair's going and the inside of your mouth is very dry. And interestingly, doctor, you're going to laugh at this when you've seen my funny little dog. Well, I've always had little dogs, and one of the instructions as I was going through the chemotherapy treatment was, do not allow your dogs to drink out of the toilet. And that really threw me. I thought, what are you talking about? Because some dogs do that. And they told me that if you allow that, the residual from your waste will make your dog lose its hair. Wow.
Did they?
No, absolutely not. No, we didn't allow that to happen.
All right.
So, and there's
That's
a
good
lot
for
of
the dog.
good for the dog. Yeah. So anyway, we have the 775-727-9400 number that you can call in. And we also have EOC at kpvm.tv. That's Eye on Cancer. And you can leave your questions with anyone or email your questions and we can answer them. I'm very pleased with some of the myths that we're able to dispel here, Doctor.
I'm so glad that the community is calling and asking questions. So I'm glad to answer.
Absolutely. We'll be right back with more.